nurse here at the hospital. I work nights, so a lot of people I don't see very often. I am currently wrapping up my graduate nursing program in holistic and nursing education. And that's through West Texas A&M University in Canyon, Texas. Come in. Come on in.
That's one of them.
And so we had to complete a project, any flavor, variety, whatever. Mine wanted to focus more on the holistic and education aspect. And so I began with something that I had not personally experienced here, since I work on nights especially, which is care transitions. Well, lo and behold, I found out, hey, we do have a great care transition program in place. But in talking with Jamie and with Ramona as to, okay, what can I do, what can I create, work on research to support the hospital staff in that process of care transitions. Come on in, thank you.
There's a handout.
We determined that, Ramona suggested changing the way we care for patients at the bedside, changing the way we do nursing. And wow, that's a tall order. So, in looking at that, what I was able to come up with, based on the fact that we already had a care transition program in place, was how can I help educate our nurses to support that process better, to help our patients be more successful at staying out of hospital. So I came up with a very, probably a 4 to 6 hour program on care transitions and the components of it that nursing staff can have the most impact in implementing. Now, before you panic, I'm not going to do that to you today. So the other thing that I created was just a short interactive teaching activity, learning activity, that's focused on a couple of the components of care transitions, which is health, literacy, and teach back. And as we were just discussing at the beginning, as everyone was coming in, we tend to have our own language in nursing and in the medical field. And I'm only 2.5 years out of nursing school, and already that language has been so absorbed into my way of interacting with people that I find myself using it with patients when it's not appropriate. When you tell a patient they're NPO, they look at you like, huh? And it's like, wait, no. Okay, let me start over. And so we also talk to patients a lot about, as we're getting ready to go home, okay, you're going to do this, this, this. We're going over their discharge instructions. And do you understand? Uh-huh. Okay, see you later. And then we're surprised, annoyed, disgusted, bummed, whatever you want to say, when they show back up a week later or a month later or 3 months later, and here we go again with the same cycle. So what I have created,
Let's turn your power back on.
Yeah. And I'm not used to your technology, not having worked with it before. I actually lived the life of the technology facilitator prior to going to nursing school. Come on, projector.
I'm wondering if that's the case, since the blue light is still on.
Surely it just went to sleep.
I can't imagine though, it just goes to sleep.
So while we're resolving that, you can kind of see on your PowerPoint handout, what I did was I took out the jokes and I took out some of the extras, such as my pretty little poem, Stand Like Mountain, Flow Like Water. Just to kind of give you a taste of what that is about, Brian Luke Seward is a instructor of everything holistic stress management. He has a doctorate in things related to health and wellness. And he has written, to walk the human path is hard, to stay put is not an option, At times my head is filled with doubt. I pause, uncertain and insecure. Then I hear these words aloud. Stand like mountain, flow like water. I walk each step in search of truth. My quest brings both joy and sorrow. Light and dark dance unified. Yes, balance is the key to life. Again, I hear the words aloud. Stand like mountain, flow like water. We come to earth to learn to love, a lesson we all must master. To know and serve the will of God is not a task for a chosen few. We must each answer the call to love. Stand like mountain, flow like water. And so this time of year, for those of you that can actually see up here, I've got a nifty
They're
little
on their way.
meme. Pumpkin spice Xanax for your seasonal anxiety. Anybody need a little bit of pumpkin spice Xanax lately? So what we want to accomplish today is to evaluate the relationship between frequent readmissions and health literacy in our patient population. To compare and contrast healthcare worker behaviors and actions that contribute to improved patient health literacy and those that contribute to decreased health literacy. In other words, what do we do that works? What do we do that doesn't? Okay? And to plan nursing interventions to improve health literacy in our local patient population. What are we going to do about it? And then, of course, as my crew on this side of the table is all familiar, when you check in on your elderly patient with dementia, any particular reason you took your pants off? This is our world, and it's not to make fun of it. This is our reality. And we can either get annoyed and frustrated, or we can just realize it is what it is and go with it and have a little humor about it. So now it's your turn to think a little bit. Think of a patient you know very well because they're frequently in our care. I can probably think of 5 immediately. What needs remain unmet that seem to bring us back, seem to bring them back to us time and time again? So just think for a moment of someone that comes to mind. Obviously no names, but as we think about those patients, what needs are we not meeting? Or is someone else not meeting? What's going on with them? Do y'all have any suggestions, any thoughts as you think of someone?
The one I'm thinking of has a ton of psychosocial needs.
And those are not fully met. And so they're back with us time and again.
Limited mental health resources for post-discharge care,
Okay.
limited support systems.
All right.
Sometimes the discharge plan is too complicated for them to adhere to. So whether it's a change in insulin, or it's monitoring more frequently, or even the follow-up exam with the physician. And they forgot to mention they didn't have a right to get to that follow-up exam. Those are the frequent things that we encounter, which they could have been avoidable readmissions.
Okay.
And I think to expound upon that idea, is insurances limit time in our facility,
Mm-hmm.
and yet the treatment plan remains complex. You don't have time to necessarily thoroughly address their health literacy. We throw a ton of information at them at discharge when they want to go, and then we don't necessarily have the resources that always do the follow-up phone call to check and see if they're adhering or if they're having any issues. And so it's just like snowballs out of control to where, once again, in a time of limited resource, where do they go? They just come back here. This is the only place.
Right.
You know?
Yeah, we usually have a problem with this projector when someone was doing something earlier or it just been left on for too long. It just needs to stay unplugged and cooled off for a little while. And it'll come back to normal. Sometimes it takes like 10, 15 minutes. So do you mind if I come back then?
Sure. We're just going to roll with it.
All right.
Is there a way we can pull that computer out to the table?
Unfortunately, no.
Okay.
Tables are
Okay, just a thought.
Sorry. I'll be back though, okay?
Technology. You probably do. All right. So, yeah, you hit on some excellent points. We are their fallback resource, and oftentimes, you know, and you think about what's a person's stress level when they're in the hospital? Are they in a very teachable, relaxed circumstance most of the time? No. What about their family? Are they in a teachable, relaxed state of mind? No. What we know about stress is that stress interferes with learning. Learning is stressful, and the majority of the time we have people who are in a state of fight or flight when we're working with them. So again, we're going to look and see what types of things that we can do to maybe help calm that stress a little bit and ease that transition as we help them improve their health literacy. Those costs of readmission, with this group, I feel sure, has all heard about the cost of readmission. 1 in 5 Medicare fee-for-service patients is rehospitalized within 30 days of discharge. 20% of them will be back. 2.3 million patients, $17 billion annually paid by Medicare for readmissions occurring within 30 days of discharge. When I visited with Jamie and Ramona back about early September, we have a lot to be proud of here because our 30-day readmission rate is actually excellent. Which was hard for me because I'm sitting there in this meeting thinking, well, yeah, but, and as you know, in my brain I'm thinking of all these people that we're seeing. Well, they may be missing the 30-day window, but they're not missing the 6-month window. We are seeing them frequently, even if they don't fall within that critical 30-day area. 20% of Medicare's total payments is for readmissions. 75% of those can and should be avoided. In October 2012, CMS said, hey, we're not going to pay for these avoidable readmissions anymore, especially if they're excessive. Heart failure, acute MI, pneumonia, those are things that should not be readmitted within 30 days. We ought to be taking care of them, getting them out of here, and getting them healthy at least for 31 days. And so those cuts that they were announcing are to increase as we go along, and further to include COPD, coronary artery bypass graft, I don't know why that's hard to say, among others. And of course, you happen to be on duty during the full moon, may the odds be in your favor. So potentially avoidable readmission is proposed as an indicator of quality of care. Are we giving good care? What's your admission rate? If it's high, maybe not so much. If it's low, yay us. Could have been prevented if there had been a provision of quality care in the original hospitalization, adequate discharge planning, adequate post-discharge follow-up, and improved coordination between inpatient and outpatient healthcare teams. And that's exactly what y'all were discussing earlier. You brought up these points exactly. We've got great teams of people in place doing discharge planning. And of course, Jamie doing that follow-up care and contact. But that coordination is always an issue. And then of course, you know, we've got to look at those characteristics. What do you see as characteristics of those patients who are frequently readmitted? And we talked a little bit about what brings them back, but are there certain patient characteristics just within their own personality traits that you see as being a characteristic of someone who's going to show back up again and again?
Well, they're limbo patients. They're not quite bad enough for certain resources, right? But they need extra support resources because they can't quite do it on their own. So they sit in that weird gray area where, what do you do? What do you do for them? You can't force them. They're competent adults. But, that's strange. middle ground.
Another characteristic, which you wouldn't think would be one, are people who are very independent in their lifestyles. They're not used to being in this type of setting. And so taking into account their preference, they want nothing to do with skilled nursing care afterwards, even if it's for a short period of time, or even home health, anybody coming into their house. They can do it on their own, even though they live alone and don't have a support system. And frequently, those patients don't fare well and wind up knocking at our door again.
They don't want to be a burden to the family, right?
There's I'm sure more than one, but one that pops into my head just has a disease for which there is no cure, and he ends up here a lot because I mean COPD is one of them. You can't always sometimes IV Medrol is the only thing that's going to help them.
Right.
To beat down that inflammation.
Right.
So,
Well, and that brings up a point, not only just one, but often these people have comorbidities.
right.
And so when you get one taken care of, i.e.
Right.
with a steroid, it's gonna flip their diabetes
Right.
into
Sure.
chaos. And so, that I think is, the trigger point for a lot of these issues. You get one under control, but it throws the other out.
I think there's a small population, but a population that does keep coming back here because it's a coping mechanism. They have needs met here that are not met in their daily life. Whatever that need is, that attention, that care, they don't have family support systems or they're not adequate family support systems. And when they come here, that psychosocial need is met. And I can think of like 4 right now.
It's commonly mental health.
Right. And there is a mental health component, even if they're not admitted to the VHU, there is still that mental health component on the floor. And that's kind of the double-edged sword of education. Give them just enough education so they know what to do to be admitted. And we have one patient that will do what they have to do because they know at a certain level that they're to exacerbate their disease process, and then they get admitted for it. And then we just take care of this person, but the mental health need isn't addressed because what's the resource,
And they become quite skilled at it. I
Uh-huh.
mean, they even know
Oh, yeah.
what to complain about as far as a potential symptom
Mhm.
that will
Ring a bell.
automatically give you a private room because you
Absolutely.
may be communicable, that type of stuff. So they become quite educated, but not in the right direction.
Very good insights. Any others?
Just people who don't want to be bothered managing their diseases, they would rather come here and have us manage them, right?
Okay.
They could take a more active role,
Sure.
but for whatever reason, they don't.
Okay. All excellent thoughts. So what are those risk factors? You mentioned several, just general characteristics. What the evidence says is age greater than or equal to 80, moderate to severe functional deficits, active behavioral or psych issues, whether they are treatable or in treatment or not, 4 or more active health conditions, some of those comorbidities you mentioned, 6 or more prescriptions.
I'm surprised it's that
So
high.
can you give me an example of 4 or more active health? I mean, I'm just thinking, whoa, that's a lot.
So your COPD patient, likely, if they've been that way for a while, they've got heart failure.
Okay,
They may have had an MI somewhere along the way.
okay.
Usually, if they're a little bit overweight, by the time they've hit, that full-blown COPD stage, they've got at least medium type 2 going on. So,
And then they might come up with some up.
exactly. Exactly.
Okay.
Which is still an exacerbation of the COPD.
Right.
But
Yeah.
it's another problem to deal with.
That patient with UTI, that patient's a good candidate for a UTI right there.
Absolutely. Yeah. And before you know it, yeah, they're just a train wreck.
Right.
So other risk factors, 2 or more hospitalizations within 6 months or 1 in the past 30 days. How many times they've been here is in fact a risk factor for them coming back. Inadequate support systems, as you mentioned. Low health literacy, which we're going to talk more about. A history of non-adherence. I like that word better than non-compliance, because sometimes it's not that they don't want to, it's that they can't. And cognitive impairment. Ambien 10, Seroquel 100, Benadryl 50, Phenergan 25, and you want something to help you sleep? Hold on, let me get some crack.
You know, I have a question.
Yes,
I'm
ma'am.
sorry.
That's okay.
The risk factors for this area, would you say that it would be maybe a language barrier too, or no?
I think that falls along with health literacy, absolutely.
Okay, just with
Yeah.
the dual, the standard
Absolutely.
majority language. Okay.
What do you, that's my opinion, what do y'all think? Do y'all see language differences as a barrier to, or a
of
contributing
course.
factor to readmissions?
It certainly can be.
Literacy on all levels, health literacy, literacy.
I just think.
English as a second language
Yeah,
literacy.
ESL.
And then culture, because of the culture, you know, well, the Kundera might have told them to do this instead of that. And, you know, there's a lot of corrective information you have to give to say, oh, no, that's really not a good idea. So, that cultural aspect.
Another risk factor, which you touched on, you said readmissions, but ER visits are a good indicator too. If they have 3 or 4, not counting the one that they're here for now that they're going to get readmitted for, that within 6 months, that definitely is an indicator that they are high risk for readmission.
All right. So what do you feel our patients need? What do you see as their need from us?
From us as a hospital?
Or individuals, or anything?
More support?
Well, yeah. External support.
Well, a good evaluation to determine what the real issue is.
And I think that teaching to truly start at admission. We say discharge starts at admission, and I firmly believe that, but that doesn't mean that I, as a floor nurse, call discharge planning and let you guys do your thing. It means that if they're admitted for congestive heart failure, I have my care notes and my stoplight on admission, and I just say, we're gonna talk about this, but I'm gonna pin it up here so you start looking at it. And then every time I go in, I start reinforcing, you're in the red zone, and here's why. They need to know what they weigh every day. We're not telling them that. We don't weigh them and then say, congratulations, you lost 4 pounds.
Yes, to say, did you buy a scale yet?
Right. So, but those are all things that I think we need to just start realigning our nursing care to have that big education component in everything that we do, every intervention that we perform or action that we perform with them. And I don't see
You
that.
bring up a great point that I actually hadn't really thought of yet. So my job as a night shift nurse is to take care of weighing them, and I'm going to do everything in my power to do it without waking them up if possible. Because, you know, that intervention is scheduled for somewhere
4 in the
between
morning.
5 and 6 a.m.
Yeah.
in the morning. So I sneak in and tiptoe in and get my little flashlight or punch the button on the side of the bed and hope that it doesn't beep loud enough to wake them up. I don't ever tell you, unless they ask me, or unless for some reason I did it earlier in the evening. Maybe I gave them a bath earlier, and they're awake, and they want to know, hey, what did I weigh? 67 kilograms.
No, in pounds.
You
In
know,
pounds, yeah.
kilograms are what's expected of me,
But it's.
but the patient has a different language.
Although, being a border town, you know, they use the metric system in Mexico. So, you know, they're not gonna know what pounds are, they're not gonna know the conversion factor.
Interesting thought. I hadn't thought about that.
I always ask them what they weigh when they come in, and then, of course, it's never right, but I'm like, well, when's the last time you weighed yourself? 1970. No, you don't weigh that anymore. But if whatever they answer is what I give them back, is the unit of measure to give them back, yeah.
Excellent. So that brings us to this concept of health literacy, because everything we're touching on goes back to health literacy. What do they know? How easily can they learn? Can they speak our language? Or do we need to speak their language? And one of the most influential things that I found, I was introduced to the AMA health literacy video, and I'm really bummed that it's not up there.
I wonder,
Let me see if it'll come on. Oh, excuse me.
What is it, AMA, health literacy?